Let's, okay, yes. Okay, now you can go ahead.
Okay, thank you. So the question goes thus: a 54-year-old woman, non-diabetic and hypertensive, had developed CKD with worsening renal function over recent years, present with a 3 weeks history of foot ulcer, fever, and malaise. The ulcer opening was more superficially, but the bone was visible. Further evaluation of the ulcer using a probe showed resistance, but using MRI did not reveal definite bone involvement. So the patient was, however, febrile on admission. So there are 5 questions that follow. There are 5 questions that follow the STEM question. So the first one is, how will you treat the ulcer? So 5 options were given. The first one is admit and give IV piperacillin, tazobactam. B, admit and give IV vancomycin plus fluconazole. The third option, bone biopsy plus wound culture and sensitivity guided IV antibiotics therapy. D, start oral antibiotics and discharge home. The fifth one is wound culture with oral antibiotics based on results of the culture and sensitivity. So that's the first question. The second question was, what is your comprehensive diagnosis? Third, what are the principles of management apart from glycemic control? Um, then what classification / staging system will you use to stage the disease? Then the fifth one is that what are the complications of diabetic foot syndrome? So going by this, trying to attempt this question, the first one is, how will you treat the ulcer? Um, I felt the correct option there is the option C, which is the bone biopsy plus wound culture and sensitivity guided IV antibiotics therapy. And the reason for this, for choosing this option is, one, from the question, we're told that the bone was visible. So whenever a diabetic foot having a visible or palpable bone like that, we have to suspect possibility of osteomyelitis. Now, MRI too was also done, but it did not show any bone involvement. However, MRI is not the definitive treatment for definitive diagnosis for osteomyelitis. Bone biopsy is actually the definitive. Even in fact, apart from MRI, even bone scan too is also more sensitive than MRI. Um, so that's why I'm going for the bone biopsy, then plus wound culture and sensitivity guided IV antibiotics. So after the wound culture, then so I felt the option C should be the correct answer. So what's your comprehensive diagnosis? So for comprehensive diagnosis, I felt the comprehensive diagnosis should be DM foot syndrome with severe wound infection on background diabetic nephropathy. And the reason for this is, one, the patient is a known diabetes, has foot ulcer. The wound is said to be a severe wound infection, and the reason for being severe is because of the patient has features of systemic toxicity, which is a fever that the patient presented with. Whenever diabetic foot infection generally are graded, which I will talk about that later. It could be uninfected, mild, moderate, severe. For the severe ones, usually once their deep tissues are involved, bone, tendon, ligaments, with features of systemic toxicity. So this is actually a deep wound because the bone is already visible. Then because the patient is also presented with fever, that's evidence of systemic toxicity. So it's actually a severe wound infection. Then the diabetic nephropathy that I also felt the patient has by background diabetic nephropathy is because being a known DM, is a known hypertensive, patient also has worsening renal function. Though the triads of diabetic nephropathy is albuminuria, hypertension, worsening renal function. From the STEM question, it was not stated that patient has proteinuria, but because of the worsening renal function, I felt patient is likely to have background DM nephropathy. So that's what I felt should be the comprehensive diagnosis. The third question is the principles of management, apart from glycemic control. The principle of management is multidisciplinary approach. We require endocrinologists, vascular surgeon, infectious disease, orthopedics, plastic surgeon, interventional cardiologist, dietitian, pediatrics, all will be involved in the management of this patient. Then offloading the wound and bed rest. This means that we have to try as much as possible to avoid weight bearing on the affected limb. And that has been shown. By the time you reduce pressure on the wound ulcer, it enhances wound healing. Bed rest too is also important with elevation of the limb to reduce edema, and that will also facilitate wound healing and blood supply. Then debridement to ensure healthy granulation tissue. Debridement is very important to remove all necrotic and dead tissue. Then after that has been removed, then we can now do we can send for wound culture. And in this case, wound culture plus bone biopsy has to also be taken because of since the bone is already visible. Then appropriate use of antibiotics. Now, the antibiotics that will be used empirically, the ones that can cover for the Staph aureus, strep, which are the common implicated organisms, things like amoxicillin, clavulanate acid, piperacillin, tazobactam can also be used. Then in addition to that, because of the bone that is visible, I also want to use antibiotics that can penetrate the bone, like clindamycin as well. Then wound dressing, usually with honey, wound dressing has to be commenced as soon as possible. Revascularization to correct any peripheral arterial insufficiency. If Doppler ultrasound is done, and there may be need for revascularization. I want to give the patient to DVT prophylaxis for deep venous thrombosis because of they may be immobilized for a very long time. They want to identify and correct any risk factors. Risk factors could be poor glycemic control, could be poor vision, could be other risk factors too. Anyone that is I'm able to identify in this patient, I will also try to identify and correct them. So this will be my principles of management of this patient. Then the next question is staging. There are several staging modality that is being proposed. The first one and the most widely used is the Medit vaginal grading system of DMFS, which grade ulcer from 0 put at risk to 5, which is whole foot gangrene. Other staging system is University of Texas, Liverpool. Then there's International Working Group for diabetic foot grading. We use an acronym PEDIS. The PEDIS stands for perfusion, extent of the disease, depth, infection, and sensation. Then there are other ones like SIMBAD too, the site, ischemic neuropathy, bacterial infection, area, and depth. That's also the acronym for SIMBAD. The other classification like the SAD classification, NOTIAM, and so on. So these are the various staging classification that can be used to grade DMFS. Then the complications include sepsis with septic shock, acute kidney injury. They may have bone involvement with risk of amputation. Post-amputation complications like phantom limb, lymphedema. They can develop deep vein thrombosis, pulmonary embolism. There's psychological issues such as depression, usually following amputation. So these are the various complications that might arise from diabetic foot syndrome. So I would like to quickly talk about DMFS based on this outline. By definition, according to the WHO, the diabetic foot syndrome is an oscillation of the foot distally from the ankle and including the ankle, associated with neuropathy and different grades of ischemia and infection. The epidemiology, neuropathy confers about 50% risk of diabetic foot syndrome among diabetics, and over 80% of amputation are usually preceded by foot ulcer. The lifetime risk of diabetic foot in diabetes is about 25%. And the burden of this diabetic foot ulcer in Nigeria is still alarming. Prevalence from several studies in Nigeria is about 11.7 to 32%. The risk factors for DM foot syndrome include previous ulcer, amputation, lack of social contact, lack of education, formation of callus, foot deformities, inappropriate footwear, poor glycemic control, concurrent diabetic complications, visual loss, and obesity. So these are various risk factors. Then, by pathophysiology, generally in diabetes, because of the chronic hyperglycemia they have, this chronic hyperglycemia results into a lot of complications following several pathways. The first one here is the sorbitol pathway, also known as the polyol. The chronic hyperglycemia, the glucose will be converted to sorbitol, which is an osmotic agent causing osmotic stress and has been implicated in a lot of neuropathy. You can also have the exosamine pathway, which results in the increase in glucosamine, and that also has some vascular has also been linked to some vascular complication as a result of glycation of protein. Then we can also have the advanced glycation end product precursors. This is actually formed as a result of non-enzymatic reaction between non-reducing sugars and protein or lipids in the system. So these glycation end products later are deposited into vessels, causing accelerated atherosclerosis and some other vascular complications. Then we also have the diacylglycerol pathway. Now, all this pathway will eventually result in increased oxidative stress, increased pro-inflammatory gene expression, endothelial damage, and so on. And that can result in either neuropathy or angiopathy. Now, if neuropathy is formed, that can result in limited joint mobility, foot deformities, and causing things popularly known as Charcot joint. And that's as a result of loss of protective sensations in joint, resulting to destabilization of this joint. You can also have lots of protective sensation, vascular dysfunction, and all these will result into increased risk of shear pressure and injury. Then for the angiopathy can result from vascular dysfunction, accelerated atherosclerosis, and peripheral arterial occlusion. This will result to poor skin perfusion. So all these will come together to form an ulcer in the leg, in the foot. Then this ulcer may be secondarily infected later. Now, the various effects of this hyperglycemic damage will result into either neuropathy, and this neuropathy can be either autonomic neuropathy that has been linked to increased sorbitol, causing deficiency of myoinositol, which are responsible to maintain the integrity of autonomic nerves. So we can also have polyneuropathy, which usually arises as a result of glucotoxicity, and this glucotoxicity results into axonal damage, demyelination. We can also have mononeuropathy, and that is actually from infarction of vasa nervorum. You can also have vascular complications too, either from macro as a result of atherosclerotic plaque deposition, or micro vascular complication, immunological, as it can also be glycation of complement protein, resulting in impairment of the complement pathway. This results into impairment of opsonization and phagocytosis. You can also have structural abnormality, resulting to Charcot joint deformities. You can have claw armor, we can have armor toe, we can have formation of calluses, bunion, and so on and so forth. So these are the various effects of the hyperglycemic damage. Now, how do they present? They usually present with paresthesias, pruritus, sensation of walking on wool. They can be feeling dead or heaviness of the foot, or loss of one of their slippers while walking without their awareness. Then ulcer can also develop without the knowledge of the person. The ulcer is usually punched out with well-demarcated margins, which are often surrounded by calluses. Now, this table shows the differences between ischemic and neuropathic pain. We can actually check that later based on the symptoms, the inspection, the appearance, the location of the ulcers, the palpation, auscultation, and also the ankle brachial index. So you can check that later. Then this picture shows the various or location of the ulcer, the neuropathic and ischemic ulcers. Then classification. I want to grade the severity. It provide prognosis on healing. It assists information of treatment plans. Various grading system for DM foot syndrome. The first and the most widely used is actually the vagina, the Medit vagina, and because of a lot of setbacks and drawbacks has been noticed with this vagina, and that's why other grading system were actually developed to actually cater for these deficiencies. And one of them is the International Working Group for the Diabetic Foot, which uses PEDIS, and that PEDIS is an acronym for perfusion. Hello. It's an acronym for hello.
We can hear you. We can hear you.
Okay. It's an acronym for perfusion, the extent, the depth, if there is if infection or sensation. Then the SAD classification, that is the first S there is size. And for the size, we are talking about the area and the depth. The area and the depth. Then the next SAD here is we have sepsis, arterial involvement, and D is denervation. So you have University of Texas classification. We have SIMBAD too, which is site, ischemia, neuropathy, bacterial infection. A is area and D is denervation too. Sorry, D is depth. You can have ulcer severity index grading system, diabetic ulcer severity score, then diabetic foot infection wound score. So these are various grading system that is used. So this table is showing the classification, the vaginal classification from 0, which is foot at risk, to 5, all foot gangrene. Then the grade 4 is also divided into 4A and 4B. 4A is forefoot gangrene, 4B is hind foot gangrene. So this next table is showing the pros and cons of different grading system. For the vagina, it's a well-established grading system. It tells us usually about the depth of the ulcer. It tells us whether there's gangrene or not. However, it does not fully address whether there's infection or ischemia, and that is the reason why other grading systems were developed. We have the University of Texas also, which actually describe the presence of infection and ischemia better than the vagina and may help in predicting the outcome of the ulcer. So we have the PEDIS, also developed by the International Working Group. It's also user friendly, and also we have the same that I've also mentioned earlier. So this newer grading system we actually developed as a form of an improvement over the initial vagina that was first described in 1981. Then diabetic foot infections. The most common pathogen in diabetic foot infection, usually in acute, previously untreated superficial infected wound, is usually the aerobic gram-positive bacteria, usually the Staph aureus and beta hemolytic strep. However, infections in patients who have recently received antibiotics or who have deep threatening infections or chronic wound usually consist of polymicrobial organisms, and you can have aerobic gram-positive, aerobic gram-negative, and anaerobes. So usually they present with polymicrobial infections for those coming with deep wounds. Then methicillin-resistant Staph aureus 2 is also a common pathogen that has been observed in those that are previously hospitalized or those that have a history of that have recently received antibiotic therapy. Now, this table shows the clinical classification of diabetic foot infections. So generally, it's been classified into four. We have not infected. You can have a wound that is not infected if there are no evidence of systemic inflammation. Then you can have mild, moderate, severe. For the mild one, either the infection, the ulcer is purulent, there's evidence of systemic inflammation, and is usually superficial. While for the moderate, the infection, there's ulcer, there's evidence of systemic inflammation, and usually deep, involving bones, tendon, muscles, and so on. While for severe, which is the index patient that we just from the question that we just treated now, is when you have moderate wound infection with evidence of systemic toxicity, fever, chills, tachycardia, hypertension, and so on. And that is what the index patient has. There's fever. So it's actually that's what characterizes severe infection. This classification is very important because it tells us how to manage patients and it tells us the treatment plan to be issued to this patient. And the importance is that usually for severe ones, they usually require IV antibiotics and they must be hospitalized. So while for the mild and moderate, can actually be treated with oral antibiotics and can also be treated as on an outpatient basis based on how they present. So that's the essence of classifying this diabetic foot infection. Then the
Yeah,
risk
Dr.
of
Rahim,
yes, sir.
Dr. Rahim, try and round up
Okay,
so that we
okay,
can
sir. So the
get
risk
to
for
the question.
osteomyelitis to if there are visible bones or palpable or probing, and that is why this our index patient too also has visible bone. That is why it's a risk factor for osteomyelitis. And once we have this risk factor, bone biopsy is actually indicated, as we saw in our index patient too. Then for the management, usually the history, we take basic history from them. Then history of ulcer, history of DM and complication. For examination, we want to cite size, shape. Then on palpation, you want to look at the base of the ulcer. You probe for depth with sterile blunt tools, and you feel for dorsal or posterior tibial position. You want to assess for light touch using monofilament, 10-gram monofilament. You want to pain, vibration, and proprioception. You want to complete a systemic examination. Then you want to check for the bedside ankle brachial pressure index, which is an indication for peripheral vascular disease, and then also to assess their vision. This is how to assess, calculate for ankle brachial index. This table shows different values of the ankle brachial pressure index and what to do um, with when we get any of the value. Once they are less than 0.5, it's critical limb ischemia, and they have to be referred to a vascular um, surgeon. So this monofilament, this tells how to use the monofilament and where to put them for the investigation. Complete blood count and ESR is very important. If there's anemia, delayed wound healing, ESR is important, especially in our index patient. If there's a suspicion of osteomyelitis, electrolyte derangement for DM nephropathy, fasting lipid profile for those that have dyslipidemia, random blood sugar, they may present with acute glycemic emergencies, glycated hemoglobin. Wound culture is actually the advocated means of investigation, not wound swab, because wound swab has been found that the yield is usually very low. So wound culture or biopsy or bone biopsy is actually what is advocated for DM foot and blood culture as well. Other investigation include X-rays of the X-ray. Other investigation include X-ray, X-ray of the feet, which is elucidation of the soft tissue swelling and other things. Then Doppler ultrasound scan is also important in them. The other investigations, then the treatment is usually multidisciplinary approach of endocrinologists, plastic surgeon, orthopedic surgeon, vascular surgeons are all very important. Then, according to the American Diabetic Association consensus treatment, the treatment modality include offloading and bed rest, as I've mentioned earlier, debridement, wound dressing, appropriate antibiotics, vascular reconstruction, limited amputation for those that are coming with gangrene. Then group glycemic control, want to correct anemia and other metabolic abnormalities they may present with them. Secondary prevention is to identify the risk factors in them and also to treat accordingly. Then the basic recommendation for DM food is that
So,
you want to identify.
Dr. Rahim,
Yes, sir.
yes, thank you very much. I think
Okay.
the others
Yeah,
for
thank you.
you share this slide. Yeah, thank you for a very lucid presentation. So the class is open for
you.
contributions and comments. So you can raise your hand electronically to make your contribution, or you send a message via the chat box. So the class is open for contribution. Okay, while we're waiting for people to contribute, let me just go to the chat box. Basically, they're applauding your presentation. Everyone is applauding your presentation.
Thank
And
you.
Dr. Aniko said CKD is also a risk factor for diabetic foot syndrome.
That has the picture of was up already. Yeah, that's what I left it.
So any other contribution?
We need contribution from the house. Those in endocrinology participants, please speak up. Oh, this is an opportunity to speak up. Those in the specialty being discussed, anything you didn't talk about or something new, please kindly update the house on these matters, please.
Dr. Shamsuddin say any duration of antibiotic use in the index patient.
Okay. Can I answer the question, sir?
Yes, you can go ahead.
Okay, thank you. So for the index patient, the duration of antibiotic use being a severe wound infection, as I've earlier mentioned, the duration of antibiotics based on the guideline should be 2 to 4 weeks. For mild and moderate, for mild infection, usually 1 to 2 weeks. Then, while for moderate or severe, usually 2 to 4 weeks. And for this patient, we have to start with IV antibiotics, being a severe infection. Then later we switch to other antibiotics. So it has to be 2 to 4 weeks. However, if later if there's osteomyelitis is confirmed, then the duration of antibiotics may actually be as up to 6 weeks. But for now, at least to start with, at least that to 2 to 4 weeks. But if there's any other
Okay. Yeah. So okay, let me still. So they said another question is, please, what is the implication of probe resistance mentioned in the question? What is the implication of probe resistance mentioned in the question? Then another say diabetic eye disease is another risk factor for diabetic foot. Dr. Chitima said consideration of the type of antibiotic use based on CKD. Education, Dr. Feisara said education of foot care to prevent reoccurrence is also important. Dr. Shamsuddin said, beside clindamycin, what are the other antibiotics with good bone penetration? Dr. Victor said maggot therapy can also be used. Dr. Momodu said using the 10-gram monofilament replace after 500 times. Using the 10-gram monofilament, say you replace after 500 times. Dr. Okay, let's just go so that we don't distract. So the first question is probe resistance. What's the implication from the
What is it?
question? From the
Okay.
question, the probe resistance, what is the, and then beside clindamycin, what other drugs have good
Okay.
bone penetration?
Okay. Thank you, sir. I think for the question, they said that if the ulcer opening was more superficially, but the bone. Okay. Further evaluation of the ulcer using a probe showed the resistance. Well, I think what I understood by that is, of course, one of the ways to examine diabetic foot is actually to use a probe using maybe a sterile tool. So after it was during that probe, because the ulcer look superficial, but it was during the probe that the bone becomes visible. Then after the bone, you are not likely to go further. So I think that is the resistance. Once they are able to, the bone has been reached, that means it's actually the bone is visible and one is not likely to move to go further again. So that's my understanding of that, what they mean by shoulder resistance. Because of, I think it's because of the bone that was reached. So except if anyone has other contrary view to that. Then about antibiotics, I think cephalexin to also have good tissue bone penetration too, apart from clindamycin. I think cephalexin, which is a first generation cephalosporin, so I think can be used. Then someone asks about vancomycin. Because of this index patient having CKD, definitely you cannot use vancomycin, even if there's MRSA, medicinal resistant staph aureus, because it's usually contraindicated once there's renal impairment. Um, sorry, is there any other
So
question?
another one, Dr. Olalekan saying, thank you for your presentation. Is it possible to conclude that CKD the patient has is due to DM or hypertension? I think patient may also benefit from physiotherapy as well as podiatrics for the second limb, which is not affected. I think you mentioned that. Dr. Eunice saying, what is the full diagnosis? Must have missed it. Dr. Abimbola say role of honey in wound care of DM foot ulcer.
Thank you. Hello.
Yes, I can hear. We can hear you. Yeah.
Okay, so for this one asks about the diagnosis. So what are the diagnosis, the comprehensive diagnosis, because that's part of the question. IFH should be DM foot syndrome with severe wound infection. I gave reason why it's severe wound infection because of evidence of systemic toxicity. Then on background diabetic nephropathy because of the history of the diabetes, hypertension, worsening renal function. Though proteinuria was not given from the question, but because of that, I felt patient is likely to be having DM nephropathy. So that's the comprehensive, because that's part of the question too. So that's what I felt should be the comprehensive diagnosis.
Okay.
Yes.
Okay. Someone said, let's not forget psychotherapy as part of management of this patient. So Dr. Araga said it is important to note that any of those mentioned mechanisms can coexist. So identification of comorbidities, example hypertension, dyslipidemia, and treatment of such to well-defined targets. Elevation of the leg might be required. Dr. Chinwe said fluoroquinolones also has good tissue and bone penetration.
Okay.
And then Dr. Jennifer is saying the comprehensive diagnosis should also include the stage of the DM foot.
Okay.
Why?
So,
and then Dr. Eguzize said, could you tell us the standard test, 4 sites, 6 sites, and 10 sites using 10 gram monofilament? I think there's a picture to that in the presentation. Yeah.
Yes.
So
Sorry, Dr. Kuti.
yes, sir.
This guy that the
all have to ask questions. You can contribute, you can teach us. This person telling us an authority. So if you have something, just tell us. Instead of asking it as a question. Thank you.
Dr. Shiku's hand has been up, please.
Okay. All right, sir. So you can go ahead,
Yeah.
sir.
Good morning. Yes. I just wanted to, wade into the diagnosis a bit, and we tend to, well, people tend to always make diagnosis similar to the one we've made: diabetic foot, background, diabetic kidney disease, all of that. But ideally, you don't start a diagnosis with a complication. The truth of the matter is, the diabetic foot is a complication. As a complication of what? Of the diabetes itself. So it is easier to say that the patient has diabetes mellitus complicated by diabetic foot. Then, of course, you state the stage and the staging classification you are using. And then another complication, of course, will be the diabetic kidney disease. So it will be diabetes mellitus complicated by diabetic foot syndrome and diabetic kidney disease. Okay. So we shouldn't start a diagnosis with a complication. Rather, we should start with the primary condition that has led us to that point.
Okay. Thank you very much, sir. That's noted, sir.
Thank you very much.
Yes, sir. Okay. Then sorry, thank you. Please, someone asked about the staging. Though I didn't put the staging as part of the diagnosis, but based on using the Medjid-Wegner classification, though bone is visible here, but we have not really confirmed whether there's bony involvement or okay. It's likely to be stage 3. Likely to be stage 3. Marginal classification stage 3. Since it's a deep infection.
Okay. And then Dr. Ekele said, is it okay to add background hypertension to the diagnosis? So that can be added also, since he's a known hypertensive also.
That's another issue entirely. Because the question now is, which came first, chicken or the egg? If you want to put hypertension into this mix, then you have to prove beyond reasonable doubt that the patient did not develop hypertension because he has chronic kidney disease. Diabetic kidney disease, if someone develops that and causes CKD, yes, the person can develop hypertension, but it doesn't mean the hypertension is an entity on its own. It's coming as a result of the fact that the person has kidney disease. We cannot make that distinction here. So usually when we have two pathologies like diabetes and hypertension occurring in a patient, and you pick the one that can cause the other. Okay, hypertension can cause diabetes, but diabetes can cause hypertension. So if the person develops kidney disease, yes. But so in this case, there's no need to start mentioning hypertension again on top of what we have already said. By the time you say somebody has diabetic kidney disease, what that means is that the person has CKD. And of course, hypertension is a complication of having CKD.
Thank you very much, sir, for the clarification.
Thank you, sir.
Dr. Remigos. Dr. Remigos, sir.
Oh. Yeah, can you hear me?
Hello. Yes, sir.
Yeah, I wanted to verify something. I heard him saying worsening renal function. I don't I got the question very well, but when you are saying worsening renal function, you tend to be talking about an acute kidney injury, depending how rapidly it occurred. You understand? And then wondering, is this an acute medicine question or a chronic medicine question? It's looking more like a medicine question, but could that be an component? Is there an AK, or we are the one that's the worsening renal loosely?
Okay.
Yeah.
Hello?
Hello, sir. Can I hear you, sir?
Hello?
Hello, sir.
Yes,
We can
am I Okay. Well, thank you for. Now, am I audible?
Yes.
Yes, thank you.
Yes, yeah.
Well, with regards to that comment, in the question, it was stated that had developed CKD with worsening renal function over recent years. So the word over recent years, definitely they are not referring to it being an acute kidney injury here. So it's likely
Yeah,
to be sick. Hello?
over recent years. That's fine.
Over recent years.
The
So that's
CKD,
what the question says. So it's like it's CKD. They are not referring to an acute kidney event here, or
okay.
acute kidney injury. So that's how the question comes over recent years.
You're
And
correct then.
usually, even DM nephropathy, by the time they get to stage 3 too, it's usually characterized with worsening renal function or diabetic kidney disease. Yes. So thank you. That's my response.
Hello, Dr. Eguzuzi, you raised your hand.
Yes, hello. Good morning to everyone, teachers and dear colleagues. Yes, I just want to respond to one of the answers she gave concerning staging of diabetic foot. We need to understand that there's a difference between staging of diabetic foot and the grading of diabetic foot. Those are two different entities. When they are speaking of the stages of diabetic foot, there are 6 stages. It's like interpreting it in terms of the natural history of diabetic foot. So it's usually described in 6 stages. That is different from the grading. Now, what are the stages? For stage 1, that is low risk foot. Low risk foot, and the foot is normal and is at a low risk. The patient does not have the risk factors that render the foot vulnerable to ulcer. For stage 2, there is high risk foot. It's just describing the natural history of the diabetic foot. So for stage 2, there is high risk foot. The foot has developed one or more of the risk factors for ulceration of the foot. For stage 3, is now an ulcerated foot. The ulceration in the neuropathic, it can be neuropathic or ischemic. And like he described during the presentation, that neuropathic foot is at sites of high mechanical pressure, like plantar surface, while the ischemic foot is at site of low mechanical pressure, like on the margins of the foot and toes. For stage 4, is an infected foot. The ulcer has developed infection with the presence of cellulitis. Stage 5 is now a necrotic foot. Necrosis can be either wet in neuropathic foot or dry in ischemic foot. And then the last stage, which is stage 6, is unsalvageable foot. Unsalvageable. So the foot cannot be saved and will need a major amputation. That is the staging, and he's just talking about the natural history. Meanwhile, the grading is different. Like if you are using the Wagner, as he has described, or if you are using the University of Texas, as described. So I just wanted to draw that subtle difference between the stage and the grade. Thank you.
Yeah. Thank you, sir.
Thank you very much, Dr. Eguzuzi, for a wonderful contribution. Is there any other comments? The second presenter can start sharing your slide. Any other contribution?
Dr. Yusuf, thank you so much for a very lucid presentation. Thank you. We appreciate you. And also appreciate active participation from the class. I think you really did justice to the question. Thank you so much. Every other person that contributed, thank you. So the second person can go ahead, please. Already 7:40.
Okay, good morning.
Yeah, good morning.
Sorry, can I go ahead to present?
Okay, you can go ahead.
Okay, good morning, my teachers and other colleagues. I'm Dr. Dalatu Ablaaminu. I'm to present question 5 of the recall of National May 2023. I want to make disclosure. Dr. Tole has made a significant contribution to how to answer this question. And then the question is, an 18-year-old boy with hemophilia was seen in pediatric clinic. He is now transitioned to adult care. The questions are, this is the patient, you may interact with the patient. How would the transfusion made? How would you transit this patient from pediatric to adult care? And then discuss important issue in transition of this patient. Then what are the investigations that you require to do to the patient? And then the last question is, how would you manage the patient from now on? So the first one, interaction.
I don't know, our teacher, this question doesn't need a simulator.
Yes, please. Yes, Dr. Atta.
Okay.
So I should stop the share.
Okay. Is Dr. Jamila around? Can you simulate for us?
Sorry, I can't. I'm driving.
Oh, okay. Sorry about that. Dr. Linda, can you help us simulate? Dr. Linda is not. So who is going to volunteer to simulate for us so that we can... Dr. Godia? Okay. Hello?
Hello. Yes, sir.
Okay. So we give 7 minutes, 5 to 7 minutes. So I'll just time. Okay. So you can go ahead. You can simulate. Yeah.
Okay,
so you have
Dr.
Dr. Abimbola.
Okay, Abimbola. Okay. Good morning, ma.
Good morning, sir.
So my name is Dr. Dalatu. I'm one of the candidates for this exam. I learned that you are an 18-year-old man, that you have an illness that started since when you are small, and it's about when you sustain a cut, or sometimes without even any injury, you tend to bleed, and you continue to bleed like that. So I was asked to interact with you in order to plan how we are going to move you from pediatric clinic to adult clinic. I hope I'm talking to the right person.
Yes, you can go ahead.
So thank you very much. So this is a situation like I gave you the background. So I don't know if you are comfortable with this environment.
No problem, I'm okay.
Okay, so you know you are transiting to adult. I don't know if you needed some of your family members to be around with you?
My dad can also be here to listen. We came together.
Okay, so he can be with us, please, so that if you needed to consult in part of this discussion, so that you can do that. Apart from him, do you need any other person to be around?
No, I'm okay with my dad
Okay,
alone.
I would have loved to have so many other stakeholders in your care, but we can go ahead to discuss. We could have had the other doctors that will continue to take care of you, and then we that were already taking care of you. So no problem. So I don't know, what do you know about your condition so far?
Well, when I was attending the clinic at the age of maybe 7 or 8, I was told that any little injury, it takes a long time before I stop bleeding. And at times when I brush my teeth, I bleed, and the bleeding became continuous and repeated until I started attending that clinic, and I felt a bit relief. But I was told that I have to move away from there. That's why I came to your place today.
Okay, sorry for that, but for now, I'm sure we've controlled most of your problem. So we'll continue to do that as time goes on. So I don't know, what's your plan? Now that we are transiting you, we may need to have a lot of meetings from now onward before you finally transit to the adult clinic. So I don't know what's your plans for your life. Like now you are becoming adult, you must have some plans ahead, because those your future ambition will determine what to tell you and how to interact with the other doctors that are going to take care of you.
Well, I want to go to the higher institution. I've done my JAMB. I want to be a doctor based on going to hospital regularly. I want to have more knowledge and be able to take care of myself and any other person having this condition of mine.
Okay, so no problem. We'll consider that as time goes on in the course of our discussion with you, and that's what we are going to tell the other doctors that are going to take care of you. So now what we need to do, we need to plan how to move you from this clinic to the other clinic. I will make sure that you are stable enough, you are with your medications. You know that we are giving you some of the medication that are for prophylaxis, meaning they are to prevent having the attack of your illness. And then the other drugs we are giving you is when you have issues with them. I hope you could remember some of these medications that we've been giving you.
I think I know some. I'm not sure of everything.
Okay, but at least you could remember most of the medications.
Some of them.
Okay, so no problem. I'm sure your dad is with the medications that we've been giving you, and since you've not been having attack for quite some time now, I'm sure you must have been taking your medication. So from now henceforth, you should be able to remember most of your medication. So get familiarized with this medication that we are giving you now. So, and the other thing is to understand those things that could actually lead to the attack, meaning that you'll be having injuries and be having blood is not stopping, you continue to bleed for quite some time. So those things, you need to avoid them, and you need to be careful while playing around like football and other things. I think you may do away with these risky playing or exercises. So you need to be careful with them. And you know that this illness is actually a genetic illness, meaning that from the parent, you inherited something from them that actually at the end of the day that you develop this condition. It's important to know that, but it's also important to let you know that it's not the fault of your parent that you have the disease. It's not actually their wish to give you this kind of illness. It's just that the nature have it that you have that kind of illness. So the other thing I wanted you to understand is
You have a minute, Dr. Dalatu.
okay, sir.
Just round up.
So the other things you need to understand is about the social support, that meaning that as you are becoming adult, yes, you own your life, but you need other people to be around so that you can always have somebody that you trust and that you can discuss your issue with him. And then the other issue that I wanted you to understand is about how to finance your treatment, because now you are transiting to adult. Your parent has done very well to you since your childhood, and then they've been paying for your hospital bills and other things. So now we need to plan how to actually source fund for the illness. It's not going to be an abrupt thing, but as the time goes on, we will start trying so that you too, you start thinking that, oh, my parent had been spending on me, so it's now for me to start supplementing what they are spending for me so that they can concentrate on the other ones, and even taking me to the hospital. Sometimes they may always be around, so now they may not have to be with you. You may have to go.
Thank you, Dr.
Probably
Dalatu.
you have to join some group or individuals in the
It's
hospital,
time.
in the
Dr. Dalatu, it's
opinions.
time. So let's,
Okay, sir.
yeah, so we can go to the other
Okay.
parts before people comment. Yes. Thank you, Dr.
Okay,
Abimbola, for simulating for us.
Yes, sir.
Dr. Atta, please allow him to conclude. Let's see how he will conclude the discussion.
Dr. Fati, I'm not sure it's necessary actually.
Oh, yes.
Yeah, because I feel as if he needs more guidance. Okay. So it might be better to just guide him. Let's just explain to him.
Okay. Do we comment after the other parts of the question, or the comments should come in now?
Well, I feel the comments should come in because we don't really have so much time, because before you know it, 8, and most people will be joining money.
So we can comment. Okay, so Dr. Tanimu, you can go ahead and comment based on this interaction.
Thank you very much for this presentation and interaction. In your first opening, you don't say you are the candidate for the exam, because it is assumed that you can't give the scenario for exam when you are interacting with him. You introduce yourself as a medical doctor, then you start interaction, but not that you are facing exam. That is why you are interacting with him. And the other thing is, you should consider that you are receiving this patient. You are on the adult side. You are the medical doctor for the adult, but you start to act like the pediatrician giving out the patient. But you should interact with him that you are the person receiving him from the pediatric side to the adult side medicine. So you should act like the adult doctor, not the pediatrician. That is, and also you supposed to also, besides that he had been with the disease for so long a time, you're supposed to also interact with him about what do he know about the disease. And which type of, did he know the type of hemophilia? If he tell you what he knows about the disease, then you fill in the missing gaps. Then did you know the type of hemophilia you have? You know there are two main ones, hemophilia A and hemophilia B. You classify them. Then you also interact with his medication, including the names of the medications he is using, and what he is facing, about the problems associated with the medication based on cost, availability, side effect, and other things. Then you also continue in that way, and if there is any change you want to introduce to him on the other side, and I assure him. So thank you, but by and large, it's a very good one. Thank you very much.
Thank you, Dr. Tanimu, for your contribution. Any other contribution?
Hello, Dr. Esther. Participants, please contribute. We don't have time so that we will come in. But if there is no response, I guess we have to come in. Any more contribution from the participants, especially those going for national? Hey,
Hello,
good morning.
man. Cheers. Thank you so much,
Morning.
sir, thank you so much, sir, for your presentation this morning. I just want to add that it's important when you're discussing with an adult, someone that just got into that stage, to be able to ask exactly what they know and be able to tell them what is relevant. Then, of course, as a male, it's important to tell him about high contact sports, those things that he can do that may give him an increased risk. For example, most of them will be playing lots of football. Some people may be even involved in sports that may risk that increased bruising or hitting that may cause the bleeding or bleeding into joints. So it's important to tell him what to avoid, the sports and all of that. And then also drugs that he should avoid, because if he's taking lots of NSAIDs, there might be increased risks of bleeding that he already has. So that would make it. And then if he's given some form of anticoagulants for any reason, he might also have that increased bleeding. So it's important to let him know about the things to avoid. Then also it's important to know his fears. Most times if you're moving from the pediatric clinic to adult clinic, you may feel, oh, these people are more wicked. I may not see my friends again. These people, how would I even interact with them? So it's important to know his fears and address them, and his whole idea about the adult clinic, and also address them. Thank you.
Thank you, Dr. Temitope, for your contribution. Dr. Chief Shitu, sir.
I hope the participants are still with their contributions so that I don't.
Please, before you come in, you know
Yeah.
Let me speak first before you come. Because once you speak, no other person will speak. You go to town and everywhere. So let me quickly just make some comments. Then you round up for us.
No problem. No problem.
Okay.
I don't know. I don't think I got the name. Who presented, please?
Dr. Dalhatu.
Dr.
Dr. Dalhatu.
I must appreciate Dr. Dalhatu. I really love his personality. I love his attitude. This question, we were supposed to start answering this question from Wednesday, Thursday. We posted it last week, and without excuse, is willing and ready to present today. I must appreciate Dr. Dalhatu. Thank you so much, sir. You make this work easy. Thank you. Thank you. Thank you. That being said, I must also appreciate the last speaker, Dr. Temitope. Thank you so much. You brought in some points. That's why we wanted participants to speak. We want to understand and know the deficiencies of the class so that we know how to come in. So participants should not be multitasking or getting distracted in class, because you feel you know something, you feel you are listening. And if you don't contribute actively, you might just be surprised when there's something lacking coming exam. You'll be amazed when in class but you didn't get the point. So please, we encourage our participants to pay attention, please, and please, and please. I also want to appreciate Dr. Tanimu before I go to the question. And I love that. I must appreciate him for that. This I was speaking, we will go for exam, they will throw something at him because he's used to speaking. He will just be talking and he'll come now, pick up one, we'll clear everything, everybody will wonder, but we all have the same platform really. So let's maximize it. Let's use it. So thank you, everyone. So the participant, I don't think you understood the question well. I don't think you understood it. So, because don't feel bad. This is not to make you feel bad. The essence of this class is to correct you. So that if at all, it might not be exam. If at all you are facing a similar situation in life, you know how to go about it. This project is being transitioned. So this is not like a time to, when somebody is being transitioned, a lot of things they might want to hear you say. The pediatrician did not come. So the one decision, but there have been several interplay between the physician and because Dr. Temitope mentioned the fact that
a child that's been transitioned, someone that's been transitioned from a children from pediatric clinic to adult clinic, they're actually very anxious. New environment, new doctors, new nurses, everything is new. They're actually anxious. What am I expecting? What is going to happen? You know, a lot of this anxiety. So that first meeting, you want to bring in the fact that you've spoken with the pediatrician, you've spoken with those that be caring for him, you have all the details. Isn't it time to ask too many questions? Isn't it time to load the patient with too many information? This is a time to make the person comfortable. You know, I've discussed the pediatricians. We have the full details of your problem. We are going to, don't worry, you won't miss pediatrics clinic at all. We have fun things here. We have fun people too. We have fun nurses. Don't worry, we will give you a number. If you have any challenges, just know that we are with you in this journey. You know, you make them feel as comfortable as much as possible. Then you're also empathic. When you're doing all of this, you're also empathic. But you put yourself in the patient's shoe if you are being transitioned from. So it's not a time to move into many information, talking about the different types, the causes, you know. So it's a time to make the patient comfortable, because at that point, patient is anxious. What if? What is going to happen? What is the future holding for me? Will I get care here? Will all the love I've received, will it continue? So it's a time to quickly chip in on that, make the patient as comfortable as possible. I think I'll stop here. Let Chief Chitu, sir.
Yes, thank you, Dr. Christabel. Okay, yes, you said some of the things that I wanted to point out. Now, the truth of the matter is, when transitioning a person from one clinic to another, and this is like the current practice now, okay, and this is one of those questions that test your ability to collaborations, okay? That means to be able to, can you hear me? Sorry. Dr. Christopher,
Yeah, we can hear you.
Yes. This is one of those questions that test your ability to collaborate. Okay, to test your ability to collaborate, because it points out that you can actually put together a small team of people to help that transition. Okay, the person is transitioning from
The line is breaking, sir. Hello, sir.
Sorry. That disrupt. This is the time for you to test the collaboration. So you can actually call in the pediatrician, the child psychologist, yourself. Everybody is there. People that the person has been seeing previously, okay, plus the new people that the person is going to see. So you're running the clinic together. It's kind of like what we do now in things like in my specialty, for instance, nephrology. If we have a patient that had diabetes, and I've been seeing them in the endo clinic, right, and now has features that are in keeping with DKD, and the patient is supposed to start seeing the doctors in the nephrology clinic, rather than allow the patient to see two clinics over and over, then you have to create a clinic visit in which you can ask the endocrinologist and the nephrologist to be present patient at the same time. Decisions can be taken together, and then it makes the management of the patient smoother. So this is like a similar type of scenario, but although this is more of a transition, okay? So initially, you're supposed to sit together with people the person has been seeing before, and then slowly ease those people out, and the new group, you know, comes in. It's important to do that because the patient was on certain management plan previously, on certain medications. You may need to know specifics. So in this type of station, if I was there, I would say, well, sir, in this particular interview I want to do, I would want to have the patient's previous physician available, okay, so that we can discuss together. And I want to create an environment that is friendly, or that is not new to my patient, while we gradually while the adult physicians gradually ease ourselves into the patient's management. Okay, so that is very important. I must say Dr. Tanimo's comment are very important as well. Okay, being able to find out what the patient is about. Okay, also is important what Dr. said, where you have to, this is not the first clinic visit that you come and start asking so many things. It's just a matter of familiarity. Oh, what's been going on? How are you doing? What have you been using? And that type of an introduction of the new team that is coming in. Okay, so this is more like a question that's going to test your ability to use teamwork and to collaborate, so to speak. Okay, so that you can have a smooth transition for the patient. Although it's not something we tend to practice every day, but it's something that we should all learn how to practice. Okay, coming together to decide about the patient. Then even after the discussion is over, you should tell the person that, look, we're still going to meet between ourselves behind closed doors to help this transition so that we can understand your management plan up to today, your clinical outlook going forward and things like that. So you have to point out the fact that this is something that is multidisciplinary. You're not just going to be the only one managing the patient, so to speak. Thank you. But very well done by the speaker. Thank you.
Thank you, sir, for your contribution, sir. Dr. Remigo, sir.
All right, good morning. Thank you to the presenter for the attempt, and thanks to all the speakers for what they've said. The truth is that most people have echoed what I wanted to say. Okay, so the very first thing is understand your question, understand the task. You might know everything about hemophilia, and yet you might not get the marks for that station, despite all the stuff you know in hemophilia. So this station, you must ask yourself, what exactly do they want me to do here? And that is the way to start, okay? So if you know exactly the task that you're supposed to do, which is to help this young man transition from one clinic to another clinic, change from one friendly, loving environment to a strange and new environment. That's just your task, okay? Your task here was not to give the patient all the stuff about hemophilia. No, it wasn't, okay? And that's why when I'm sorry that I was the one that said that there's no need to give you the presenter extra time, because I felt it was already in the bush, kind of. We had to bring him back, okay? So of course, this place is a learning platform, and that's the essence of this place, so that you begin to understand more. If fortunately you face this kind of question in the exam, it might not be exactly like this, but it might be in this form. You'll be able to answer it very well. Okay, so and then you started with using terms like you are transitioning. No, transitioning, even for some of us to call the transitioning is difficult. Okay, so use simple terms that the patient will understand. Before the guy immediately say, God, these people in this clinic, they are big grammar people. Oh, how will I cope? As moving away from what is required of you. So, but everybody has said the things that are important in this particular scenario. Thank you.
Thank you, sir, for your contribution, sir. Any other contribution or clarification? Okay, Dr. Rukaya in the chat box said there's a hemophilia readiness transition assessment template that can be used to assess the patient's readiness and identify issues to be addressed. Dr. Temitope also is adding to the comment and say, as part of rapport and also as part of rapport and empathy, a word of encouragement, support, acknowledgement could also be voiced out in response to the candidate, indicating he wanted to be a doctor. All right, and I think Dr. Rukaya said she will post the hemophilia readiness transition assessment template on the group.
So Dr. Atta, we're done.
Yeah, he has other parts that he has not answered yet. So I don't know, probably will continue tomorrow. So
Yes, we'll continue that tomorrow. It's 11 minutes past 8. We have to close the class. But I must appreciate his effort, really. It's amazing. So thank you so much, Dr. Dahatu. I appreciate you. Thank you, Dr. Dr. Yusuf, the first speaker. I did wonderfully well. Dr. Atu, thank you so much. It was a wonderful attempt. That's the essence of this class. National questions are not the regular exam questions. So most time, usually advise you look at the question, take some time, understand the question, and use a minute. So outline your plan. This is what this thing, okay, this is what I'm going to say. So in case you are running out of time, if you look at your paper, we really advise that once you get any station, always request for a paper. Please, can I have a paper? They give it to you. So, okay, this is the question. Start writing out what you feel that question is about and what you want to say. So in case you miss anyone, you quickly look at your paper, it will help redirect you. So please, we are all learning. No, it's even better we make some of these mistakes now. So that once you are in the exam itself, these mistakes will be almost zero. I want to appreciate our class chair, Dr. Atta. Thank you. The participant, thank you for your active participation. Dr. Tanimu, Dr. Temitepe, all the other doctors, I can't list out everybody's name. Thank you so much. Facilitators, Dr. Kunuga, Chief Cookie, Chief Bansi, Chief Chitu, Chief Ramigos, Chief Manza, Dr. Aina, I cited Dr. Aina, these are our teachers. Dr. Aina, Timothy, Dr. Jennifer, Dr. Yusuf, and every other fellow present in the call. Thank you so much for your presence. I appreciate your presence. We'll end the class now. Chief Bansi, sir, please, a word for the class. Chief Bansi, Chief Chitu, a word for the class, then close it.